To start out the day, we're going to hear a little bit, we're going to start at the beginning of the process. We're going to start hearing from the NIH, and we're going to then hear from the FDA. So we want to really go through the process of what does basic science mean, all the way through to how do we get to the point where devices and drugs are going through the regulatory process. So to kick us off, we're going to hear from Dr. Tony Punturieri. He is a program officer, Division of Lung Disease at the NHLBI. In this capacity, Tony administers a variety of portfolio of grants and contracts in the area of COPD and the environment. Specifically, Tony participates in the development and administration of programs that aim at the understanding of COPD disease mechanisms, prevention, and the testing and evaluation of COPD therapies. That's his formal bio, but many of you know Tony is a real champion for COPD, as a champion for the National Action Plan. And without his leadership at the NHLBI and that of his colleagues and Dr. Kiley and others, we wouldn't be where we're at now, and especially with the National Action Plan. So personally, thank you, Tony, for being here, and I will kick it off to you.
Thank you, Jamie. And I'm not the only person working there, as she mentioned. So it's 2 or 3 of us that are, carrying this flag at the NHLBI. Wait a minute, because I have my personal point. I thought we were done with the day because it's engage, educate, and inspire action. Just from your introduction was enough to hear that you're all inspired, all engaged, and you're all in action. So we can go home now, basically. No, as Jamie said, I want to just give a brief introduction and be as lay as possible on what NHLBI is, what NIH is. Let's see. There we go. So there's, I copied this from our website. As you can see, there's 2 symbols here. One is the big one for the whole NIH, and there's 28 institutes and centers, and that's because the way they were funded and created by Congress. Remember, we respond to Congress, and Congress gives us money every year to develop and fund programs every year. And so that's the big flag. Within the NIH, NHLBI, heart, lung, and blood, you see, covers three parts of your body, of our body. There is NHLBI. But the mission is the same. It is to foster fundamental creative discoveries, innovative research strategies, and their application as a basis for protecting and improving health. Develop and maintain and renew scientific human and physical resources that will ensure the nation's capability to prevent disease. Expand the knowledge base in medical and associated science in order to enhance the nation's economic well-being and ensure a continued high return on the public investment in research. And last but not least, exemplify and promote the highest level of scientific integrity, public accountability, and social responsibility in the conduct of science. So it's pretty heavy, as you can see. And to do that, we support research in many fields, in the causes, diagnosis, prevention, and cure of human diseases, in the progress of human growth and development, in the biological effects of environmental contaminants. As I said, I do COPD and environment, but we have an institute that is just dedicated to the environment. It's called the Environmental Institute. In the understanding of mental, addictive, and physical disorders, and by directing programs for the collection, dissemination, and exchange of information in medicine and health, including the development and support of libraries, because knowledge is power, right? And the training of medical librarians and other health information specialists, which is part of the education. Thank you.
Of course, I just turned it off. But
Next. It's on the side, those 2 on the sides. The one on the right. There we go. So now we jump to a story. And Jamie has asked me to bring you a story of research that goes basically from the test tube all the way to a clinical trial. And this is just to give an example of how we do research. And actually, as our directors, ultimately, even Dr. Collins says, you never know where the discovery is coming through. I always give the example, you probably know this, of the discovery of penicillin, the antibiotic. The guy forgot the plate in the oven. and he forgot the plate in the oven, and then Fleming. And then he took out the plate, and he saw, wow, something is happening here, but he didn't know what. It happened to be in a research entity. He went down the corridor. There was another guy that was studying the bacteria, in this case, because it's a product of bacteria. And the other guy said, wow, this is very interesting. What you have here is something that killing bacteria, and that's how penicillin came out, and so on. So isn't that, you know, an interesting connection of discovery, knowledge, different people with different knowledge that come together. So Marfan, I'm going to try to keep it very simple. Marfan is a genetic condition. It's a connective tissue disorder, so it's a structural disorder. The major problem with Marfan patients is that among the structures that it affects are the vessels of your body. And the big one, the aorta, the one that pumps out of your heart, blood to the body, turns out that because it's weak, pump, breaks out. And so these poor people die because the aorta breaks down. And so people wanted to go and see what's the cause of it. And the major part is because this protein, which is called fibrillin-1, it's deficient. Think about for those alpha-1 patients that are here in the room, same kind of thing. And so people started to come up with how can we study Marfan. They came out with mouse model and tried to see how we could learn more about it. And they found out that it involved dysregulation of something that we all do, that we all make. It's a protein. It's called transforming growth factor beta. Like all the stuff that we do, when you have a good level, it's good. When you have a low level, it's not good, as well as you have too much, it's not good. Next slide. And so this is a paper from 2003, a research paper. It says dysregulation of the transforming growth factor beta activation contributes to pathogenesis of Marfan. So, transforming growth factor beta could be a path. The interesting thing is that this group described in the mice, remember we're working in mice right now, enlargement in their distal airspace described as emphysema. And so they analyzed the lung phenotype of the mice. Next slide. And while they were doing that, they had a mouse model of Marfan and says, how can we treat it? We know that there is this drug, which is called Losartan, which is, some of you may even take it. It's a drug that affects blood pressure. So it lowers, if you have high blood pressure, it lowers your blood pressure, but it affects the transforming growth factor pathway. And so they tried in this mouse model to see if it was blocking the development of the enlargement of the aorta. Interesting enough, it partially reversed also not only the aorta problem, but also non-cardiovascular manifestation, including impaired alveolar septation, the enlargement in the lungs. A drug is already in clinical use, merits investigation as a therapeutic strategy for patients in Marfan. Everybody would say that. That's why we go from the tubes to the animal model and so on. And so that was 2003, 2006. There's a date here. This group submitted a grant to NIH to get funded because they wanted to do research in a novel treatment to prevent COPD progression. If it worked in Marfan, if it stopped the enlargement of the lungs, could it work in humans? That's the question here. And so they wanted to give, and it's here, you can read it, I'm reading it for you. Losartan was one, they planned to do a little trial in about 180 people for Losartan or placebo. And look at it, same way that for alpha-1, those patients, they receive alpha-1 and they were analyzed by CT scan to see if it was stopping the progression of the disease. The same way was planned here. Next slide. The sad part is that Losartan did not work for Marfan patients. Among children and young adults with Marfan, no significant difference. If you click again, there should be, and this is two different trials, one in France, one in the States. They both came to the same conclusion. So it doesn't work for Marfan. Next slide. But does it work for emphysema? And that's the question that we are trying to address right now for a trial that is called LEAP for short. It is Losartan effects on emphysema progression. The trial is ongoing, was funded by us. It's the same group from Johns Hopkins that is running it. I don't know the results yet, of course, but I know that we are at 80% of enrollment of patients. It's studying 220 patients, and we have already enrolled 166 as yesterday. We'll know.
The Foundation is helping enroll patients for this trial. You maybe were going to say that.
Yes, thank you, Barbara. Though, but that's that's good. That's good. That's good because it's a good. Maybe I was forgetting to say that, but this one, and we are doing actually another two with the help of the COPD Foundation. And the help is sometimes is money, sometimes is in kind. It takes a lot of effort from all different parts to get there. Incidentally, and this is a little parenthesis, turns out that Losartan had a recall for my colleague from FDA because recently it was found to be produced with some contaminants, some groups I'm not going to go into detail. And the FDA said you can't take these Losartan pills anymore, so we had to scramble to find out pills that didn't contain contaminants. Even though, remember, the level of contaminants that the FDA scrutinizes is much lower and deems them dangerous than the one you buy at the supermarket with your fruit or veggies. That's a parenthesis. But of course, I mean, you need a different perspective. Next slide. So other things that we have done and that we do, and it is just to show that we are trying to answer important questions for the patients. And we did a trial for the prevention of exacerbations, and this was published in 2011, and it uses azithromycin. Some of you may still use or may be using azithromycin even as we speak to prevent exacerbation. For example, I know John was using azithromycin and was very happy about it. And it just came out in the recommendation of the GOLD guidelines for patients with COPD. We tried to address the role of statins, the drugs that some of you, again, may take it for prevention of cardiovascular disease, because looking at the literature, it looked like the patients on statins were doing better. But once we excluded all patients that had cardiovascular disease, and you probably know this, 35–40% of patients with COPD have cardiovascular disease, so this was targeting the other 60%. It didn't do anything for these cardiovascular disease-free patients. And the other trial that we recently did was to test whether long-term oxygen treatment was better at preventing death or hospitalization among patients who had stable COPD but with moderate resting desaturation. We knew that oxygen was good for people that had severe desaturation, but not for this fraction of people. And the trial, which actually was run in coordination with CMS helped us. And that's, again, another entity that has to come to the table if we want to make progress in the disease. With their collaboration, we established that for these patients, there was basically money wasted. In other words, redirect your effort to something else, to a different population. Next slide. And now I'm mentioning a couple of different parts that touch, in this case, to hospital readmission, which is something I'm sure is dear to you. And this is a paper that came out basically in the spring, in April of this year, that tells us that these patients need special attention. Right? It's not the healthcare system, but it's the way you discharge them and you take them after discharge that is important to prevent 30 days rehospitalization. Next slide. The other thing I like to point you at, and it has always puzzled me, is the mortality, people that die of COPD. And this is in green females and in red males. And I divided, this is data from CDC. You can do it yourself. If you have a computer, you go at this wonderful site that CDC has. It's called CDC Wonder. And you see basically the two lines are attached. Here is years from 99 to 2017 and the number of deaths. Click again, please. No, too many. Yeah. In 2017, a lot of people died of COPD. With the opioid crisis, of course, it switched from third cause of death to fourth cause of death, considering that about 70,000 people die for opioid overdose. The majority are women. I mean, this is reflected following that in this graph by the age fraction of 75 plus, where many more women die of COPD since the year 2000 than men. And that's another puzzling question that needs to be addressed. Why is there a difference? Is it just a bias of survival? Of course, we know women live longer than men, so that's one possibility. But the other question behind is, are these women receiving adequate treatments as men? And where are they? Are they in urban America? Are they in rural America? Those are all questions that needs to be addressed. And as NIH, as NHLBI, we push the envelope a little bit, but once again, it's not an answer that we can come up with by ourselves. Next slide. So, you know all the numbers, the personal suffering and the global sufferings, because as you know, there is about 15.5, 16 million of patients that are diagnosed, and we think there is another probably 4 to 5 out there that do not have a diagnosis. But it was through patients' effort that Congress wrote to us in November 2014, and wrote to us, meaning to NIH, here is directed to Francis Collins, and to CDC, the then director of CDC. And they asked, we request that the NIH and CDC create a national federal action plan for COPD in fiscal year 2015. We hope a strategy will be realized as soon as possible. And here are the members of Congress that signed the letter, Louis Joyce and Shea Porter. Next slide. In response to that, in January, NIH and CDC said, NHLBI, because it fell upon our institute, because we do lungs mostly, non-cancerous lung, NHLBI will be convening a meeting involving federal and non-federal stakeholders, including patients, to develop a national action plan to coordinate activities targeting the disease, particularly those address the Healthy People 2020 objectives, which I don't know if you're familiar with it, is the standard of the nation to reach a certain level of health in all the diseases you can imagine of. And so we convened a big meeting at the end, little step one after the other, in the spring of 2016, where we had more than 200 attendees. Some of you were there, patients, caregivers, healthcare providers, industry leaders, academic leaders, and 14 federal partners. And the idea has been, since the incipiency, not to do this as a top-down approach, but as a grassroots movement, so that all voices would be considered and heard. And originally we had 6 goals, and then while we were doing the final write-up, we shrunk a little bit and we came to 5 goals. And I know that Jamie is going to talk about the plan more extensively later, so let's move on the next slide. These are the aims, you know them. Again, Jamie is going to address. What do we do? Each one of us has an environment, a set of capabilities. So we do mostly research, as I talked about. We also have a program that is called the Learn More, Breathe Better program, that is to promote awareness both in patients and in providers. But what we do best, what we've been doing best, is of course research. And so increase and sustain research to better understand prevention, pathogenesis, diagnosis, treatment, and management of COPD. And so we try to expand, coordinate, and optimize COPD research efforts, improve methods for the earliest detection. And that's one of our, we need to take care of both the patients that already have advanced COPD, obviously. As I sometimes say, put the fingers in the dam to avoid the collapse. But also, we need to think in terms of saving lives at a much earlier point, where maybe we can intervene and do better at stopping progression of the disease. And that's where NHLBI, NIH comes in. That is, think for the future, think for the moonshot or the flight to Mars kind of research. Define and characterize the pathogenesis of COPD heterogeneity, because the more we learn about it, the more we know that it's not only the genetics of alpha, but there are a lot of ins and outs in each patient. Each patient is different from the other. And we are trying to bin them, but each patient deserves a personalized treatment because of that. And there it goes. Develop personalized medicine for COPD based on the pathogenesis and heterogeneity. And of course, promote research that can help to prevent the onset and progression of COPD. And one of the places where we're going at is rural America, because we realize in collaboration with CDC that it's clearly an underserved area for many things, but in particular for COPD. We have seen that the mortality has not diminished with time. There are statistics out there from 1999 that it shows whereas in urban it goes down, in rural America it stays flat, and I'm talking about mortality. Whereas for other diseases, for example, yes, there is a little gap between urban and rural, but they are both going down, like cardiovascular, stroke, and so on. And so we are actively working with HRSA, which is a federal partner, and other partners to try to move the needle in rural America. And we are doing that, meeting with them and set up major takeaways, for example, that right now are on the plan. Payment and reimbursement in rural areas are something that we are trying to tackle. The rural workforce that, of course, goes well beyond the treatment of COPD, but many chronic conditions are in that. COPD treatments in rural settings, how are they delivered? Is everybody getting them? And so on. How is the education, for example, of the providers in rural setting? Altogether, addressing comprehensive COPD care in rural areas. And this is my last slide. And as I mentioned many times, is a big puzzle, but each one of us brings one or more pieces to the table. And I think, as was said before at the beginning, earlier this morning, it takes the effort of everybody to realize what we all wrote, next slide, in the National Action Plan. And I think I'm done. Thank you. Thank you. David came in. Maybe you want to.
Okay. Thank you, Tony. Appreciate it. We're going to take questions, but we're going to go through the FDA presentation and then have a little bit of a group question and answer session with the time we have allocated. Great. Okay. So I think, from what you hear from Tony, that it's clear that NHLBI helps fund discovery science that's critical to finding those unexpected answers. They help push large trials in clinical issues that can inform treatment or can redirect where we're going and looking for new treatments. And I think there's more questions to answer than there is funding to allocate. And that's why one of our first priorities, one of our main policy goals, is to increase funding for NIH research. And I think you will clearly see why as we go throughout the day. And as Tony has illustrated some great examples for us. So we're going to move on quickly to our next presentation, and then we'll take some questions. So we are joined by Susan Chittooran, and I apologize for butchering your name. She's a patient engagement project manager on the patient affairs staff within the Office of the Commissioner at the FDA. Susan serves as the central point of contact in patient affairs for patients, caregivers, advocates, all those who wish to engage with the agency. She resolves some patient-related concerns and inquiries and serves as the liaison between patients and subject matter experts within the FDA. Susan also assists in identifying and coordinating patient stakeholder participation in FDA meetings, something we want to talk and encourage, how you can infuse the patient voice in the FDA. Susan spent 3 years also at FDA's Office of Health and Constituent Affairs and has worked in the New York office of the Women's Bureau of the U.S. Department of Labor for 6 years. So thanks, Susan, for joining us, and we look forward to hearing more about how the patient voice can be in the FDA.
Hi, can everybody hear me in the back? I have a kind of a soft voice. We're great, okay. So thank you so much for inviting me to join you here today. I'm thrilled to be here, and I'm also thrilled to talk a little bit about the FDA and how we work with patients, advocates, and caregivers. Again, my name is Susan Chittooran, and I just want to say that I have cards up here up front, so if there's anything that you have questions about after today, then I'm happy to meet with you or chat with you afterwards. So I just want to mention that before I get started. Okay, so this is just a quick overview of today. I'm just going to talk a little bit about my office, what we do. I'm going to also talk about other ways to share your perspective through programs that we have at FDA, and then, time for questions at the end. So a little bit before we get into my office, I want to just show you this chart. So this is a chart that talks a little bit about the ways that FDA has worked with patients throughout I would say the last 40 years or so. And I know the text is kind of small, and I'm not going to read through everything, but I just wanted to say that we started formally with working with patients in the 80s. That was as a result of the HIV/AIDS crisis. That inspired FDA to bring the patient voice to advisory committee meetings, in the 80s and 90s. Then if you look at the chart sort of towards the bottom, 2012 was an important year for us. That was when we first started our initiative, the Patient-Focused Drug Development Initiative, and I'll talk a little bit more about this in detail in some of the other slides. 2015 is when our Center for Devices at FDA launched the Patient Engagement Advisory Committee. Again, I'll mention a little bit more about that. And then my office was started in 2017 in December, so we're about a year and a half old. And that's pretty recent. And then if you look up towards 2018 and 2019, towards sort of the end of this line here, you can see all of these different types of things that we have done. We've really done a lot towards, the last decade or so in terms of trying to incorporate patients and caregivers and your advocates' voices into the FDA. So a little bit about my office. So we are housed in the Office of the Commissioner at the FDA. We report into the Principal Deputy Commissioner. And what do? We work with FDA. FDA has 6 centers, and we work with 3 of them, 3 of the medical product centers. So we work with the Center for Drugs, the Center for Biologics, as well as our Center for Devices. All of those centers have staff at FDA that focus specifically on ways to get the patient voice into their work, but it's specific to their product. So because of that, we felt that it was important to have an office that sits in the Office of the Commissioner that we can help bring all of those voices together. So for example, if you were a patient and you have a concern and you want to talk a little bit about your disease or condition, you might have issues that are not just specific to a drug. You might also want to talk about devices as well. So we kind of help to bridge that gap so that we're looking at patients and the issues that patients and caregivers bring up in sort of a more holistic way. And how do we do that? A couple of different ways, which I'll go through a little bit more in detail. So one of the ways is we do public-private collaborations and partnerships with groups outside the FDA. We do cross-cutting activities. That sort of goes back to what I was mentioning about working with FDA's 3 medical product centers, and look at the best ways to continue to engage with patients and caregivers in a way that is beneficial for you as well as for us. And then one thing that we are trying to do is we are trying to improve some of the ways that we communicate with patients. And so that includes like the website and social media. So this is a little bit about a group that we would work with. This is an example of a, so FDA works with EMA, European Medicines Institute. They're basically the European equivalent of FDA, so we share best practices with them in terms of what are they doing in terms of how to engage with patients and what are we doing. And so we talk a little bit about that as a way to beneficially enhance the way we communicate with patients and how patients can communicate with us. The PEC, we have a lot of acronyms at FDA. I don't know if anybody's very familiar with FDA, but we have a lot of acronyms. So PEC, Patient Engagement Collaborative, is one of the groups that we have. This is an opportunity for patients and caregivers to talk to the FDA directly, a little bit about about medical product development, so drugs, devices, biologics, communications, and how we communicate with patients. This is an effort that we started. Our first meeting started last year. It was actually late last summer. And this is a photograph of some of the members of the PEC. As you can see, it's a small group. And the people in the photo, they represent a variety of different diseases or conditions or disorders. And they go through sort of a nomination process and an application process to become a part of the collaborative. This is something that we do in collaboration with, I don't know if you're familiar with CITI's Clinical Trials Transformation Initiative. So the group meets every month by phone, and then we try to meet once or twice a year in person as a group. And the members on this committee sit on there for 2 to 3 year terms. So we just started last year. So coming up in the future, we may have more opportunities to get involved with that. So this is an example of some of the stuff that we've been trying to work for in order to improve our communication. So one of these things is we're trying to improve our website. I'm not sure if anybody has had a chance to look at our website, but we are trying to make it a little bit more patient-friendly and easier to navigate. One of our more recent things that we've done is we've started a video series called Patients Matter. It helps patients and caregivers understand basically a little bit about what I'm talking about. How do you get involved with the FDA? What are the different ways to do so? And then we're thinking about adding more videos to the series. How do you prepare for a meeting with the FDA? What is expanded access? Topics like that. One of the other things that we started, this is pretty new. Our office in general is very new, but this was something that we launched in, I believe it was April of this year. So we started something called Request to Connect. So one of the things that we heard as an office that focuses on patients is that patients and caregivers or advocates didn't really know where to go if they had questions for the FDA, or if you wanted to meet with the FDA, where do you go? And so we found that because FDA is so large, sometimes people perceive FDA as intimidating, there wasn't one particular place where you could go to do that. So because of that, we have worked with a lot of the centers within FDA to create a portal. It's called Request to Connect. And this is just sort of kind of a snapshot of what the first part of the form looks like, but it's basically a little web form, and you can go through and you can select, there's little radio buttons here. You can select if you're a patient or you're a healthcare professional or you're a member of a patient advocacy group, and then you can select whether you want to have a meeting or you have a specific question. And then I know it doesn't show the whole form on here, but there's a section where you can type in your question. There's a section where you can say, my question has to do with a drug, or it has to do with a device, or maybe you don't know, or maybe you just have a general question, like how do I get involved with the FDA? So this is the place where you can go to do that. So you can submit meeting requests on here, and you can also submit questions as well. Okay. And one of our other initiatives that we started in patient affairs are listening sessions that we do with patients. This is a pilot program that we are doing. We have a memorandum of understanding with NORD. And one of this initiative started, our first listening session was last fall. And so we've had, I would say, I don't know, 5 or 6 of them so far. So what are they? They help bring the patient voice to FDA and the caregiver voice to FDA. So what does that look like? We have, the listening sessions involve FDA review staff, and they also involve a small number of patients and caregivers. So we usually try to keep the number small because we want to be able to hear more directly from patients. So we usually have about 7, 8 patients or so that can speak a little bit more in depth about their experience. And what do they talk about? They talk a little bit about their disease or condition or their disorder, either from the patient perspective or a caregiver perspective. And this helps educate the FDA review staff a little bit about what your day-to-day experience is like. These aren't specific to a particular product, but it's more about, you know, how are you managing and living with your disease. This is information that's important because in our office we believe, and I would say throughout the FDA, we believe that patients and caregivers have a perspective that only you can understand. We don't understand necessarily your day-to-day experience. So there are things that you have and you know that would be very valuable for us to know. So this is an opportunity for people to talk a little bit about their day-to-day, and FDA review staff, people who are, you know, potentially reviewing products, can ask questions a little bit to you about maybe what your preferences are, or if you are going to a clinical trial, what you know, is this too far to travel, or what would you be willing to do? Like, if there are side effects, or is this something that you'd be willing to tolerate? So it's a little bit more of a more of a back and forth conversation to help FDA better understand your perspective. I do want to say that for listening sessions, these are something that either FDA can request, so we might say, we might be approached by one of the FDA centers that say, I want to learn a little bit more about hemophilia, for example. And so as a result, my office would then work with NORD to try and find patients and caregivers so that we could have a conversation about hemophilia. Another example is patient groups can also request listening sessions as well. So what would that involve? You would then, as a patient organization, an advocacy organization, you would then submit a request to us through Request to Connect, which I mentioned earlier, or you can email me too, and we can help get that process started. You would then be responsible for bringing in patients and caregivers, developing an agenda, and then of course leaving time for questions and answers. With the listening sessions, since it is a pilot, we started off with in rare diseases, but our goal is to be able to evaluate whether this is something that we can do in other disease areas, including non-rare diseases. So I just want to mention that. In the next couple of slides, I'm going to talk a little bit about other opportunities for patients to connect with FDA outside of my specific office. And as I just wanted to mention again, is that because our office works very closely with all of these medical product centers, we do know those staff. So if you have questions about any of these initiatives, I do have their contact information as well, but you can always reach out to me and we can get you to the right place, or I can help address your questions. So one of the oldest programs that we have at FDA for patients is the FDA Patient Representative Program. So with FDA, we have advisory. Are people familiar with advisory committees here at all? Yeah. Okay. So with FDA advisory committees, as part of the meeting, we have one or sometimes two people that sit at the meeting who can provide the patient and caregiver perspective. So those are people who either might use a product or a similar product, or they have experience with the disease or condition or disorder. And so how does FDA get that patient or caregiver voice? Well, we get them through our patient representative program. Our patient representative program is managed within the Office of the Commissioner, and there's about 200 people in the program, and those people represent 300 different diseases or conditions. To get involved with the program, you should be comfortable knowing obviously about your disease or your condition, being familiar with your treatment, possibly other treatments, and be an active voice in your community. Are you involved with a patient advocacy organization, for example? You also have to be willing to speak, hopefully with public speaking, because with advisory committees, you're up there talking. You have to be comfortable sharing your perspective. And then the other main thing about the patient representative program is that everybody that is part of the program has to be screened for conflicts of interest. That part is usually the most time-consuming part. We just want to make sure that when you are speaking, that you are speaking on behalf of your own experience, and that we are aware of anything that might shape your experience in any way. So this is a program that anybody can be involved with if you want to speak a little bit about your disease or your condition. And these are some of the other initiatives that our medical product centers have. And I'm not going to talk about all of them. I'm just going to pick out a couple of them. And this is broken down by the 3 medical product centers. So the top, drugs, then we have devices, and then biologics. So at the top where it says PFDD, so that's one of the main ways that people have, if they've heard about FDA and working with patients, they've usually heard about that. The patient-focused drug development meetings, they're large public meetings. We have done them where FDA has organized those meetings, and we've also had other groups organize those as well externally. And so if you look, FDA started this initiative in 2012 with the internally FDA-led patient-focused drug development meetings. We did 24 of those. Externally led patient-focused drug developments, we've done 25 of those. So groups can, if they're interested, go through that process. You can organize one of these meetings yourself. If you're in the DC area, you can host those, you can webcast those. One of the things that come out of those that is most meaningful are the voice of the patient reports. Those are reports that are then posted on your website that FDA can then link to. This is an opportunity to talk a little bit. They're similar to the rare disease listening sessions that we have, but sort of in a much larger scale. And these meetings are focused on drugs or biologics or both. So that's one thing that you can do. If you're interested in getting getting a patient-focused drug development meeting, should generally start about a year in advance, and you submit a letter of intent. It's like a 3-page letter, sort of talks a little bit about why you're doing the meeting, what you hope to gain, and you submit that to the FDA. So if you're thinking about that, start thinking about it early, because you do want to submit that about a year before you're hoping to have the meeting. Our Center for Devices, one of their biggest initiatives is the Patient Engagement Advisory Committee. So they announced this initiative in 2015, and the first meeting for the Patient Engagement Advisory Committee was in 2017 in October. So it's similar to other advisory committees that we have at the FDA, but the big difference is that everybody who sits on that committee is a patient or a caregiver. And they talk about their experience as a patient specific to devices. So last year, they had their meeting topic focused a little bit on data and registries and social media, and how can you capture patient perspectives and patient voices on social media or through registries, and is that how can FDA then use that information? They had a meeting, the last 2 years they've had it in the fall of each year, so hopefully they should have another one of those coming up soon. And that is, I have to say, one of the most well-attended FDA advisory committee meetings. A lot of people attend by web because a lot of times travel can be difficult, but that's a popular one, so keep your eye out for that one. Oops. Okay, so, and this is a little bit about other opportunities to connect with the FDA. Hitting this too hard. So one of these, this is just sort of more broadly, is we encourage patients and caregivers to attend public meetings. A lot of times patients don't attend these because they don't know about them. So we've recently streamlined FDA's overall website. So if you're curious about how to attend a public meeting or what's going on, if you go to our homepage and you scroll down to the bottom, there's a section that says meetings. You can click on it and it'll show you sort of, it looks like this. That's what it looks like if you're looking on your phone. It'll show you all of the public meetings that are coming up. There's a lot of meetings on a lot of different topics, whether they're drug specific or device specific, but this is the best way to find them. You can also reach out to my office as well, and also check our Twitter feed, because we often post meetings on that are relevant to patients or that patients and caregivers might be interested in. The other thing that we recommend is becoming familiar with the Federal Register. So you know, as I mentioned, when we have public meetings, we often post in the Federal Register. If you want to comment and provide your perspective, you can do that through the docket. We often at FDA send out information about things like that where you can participate. So that's one way to become familiar with it. From our FDA patient page, we have a guide and a resource for patients who don't know how to submit comments. I think it's literally called "How do you submit comments?" But if you go to the FDA patient page, it's from the FDA page. You just click patients. You should be able to find it sort of towards the middle of the page. And then finally, I just want to talk a little bit about MedWatch. So MedWatch is a program that FDA has started in 1993. This is for products that have already been approved, so they're already on the market. And why do we have this is because sometimes you might experience adverse events or side effects that you want FDA to know about. Sometimes during clinical trials, it's not always possible to understand all of the side effects in a product, so that's why we have MedWatch. So this is a way that you can report information to the FDA. So are you seeing information about side effects of a product? Are there things about interactions? Is the labeling unclear? All of these things are things that FDA may want to know about. So you can actually report this to FDA. You click the red button that says report a problem. And then you can also get information from the FDA. So if there are informations about recalls or we've updated any of our safety information, you can get some of this information. So the green button is stay informed. So you can actually go online and request that they email you. So I know we mentioned Losartan earlier. So when that came out, we would communicate that through MedWatch as an example. So the website for that is fda.gov/MedWatch. And I know that, I think you're getting these slides later, but I'm just putting this up there. But these are some of the contact emails for the specific centers. And then again, as I mentioned, you can always reach out to me in my office and we will get you to the right place or right person. And so I think the final thing I just want to leave you with is when you're in doubt and you just don't know who to go to or where to go to at FDA and you have a question or you need to know something, please contact my office. We're sort of the front door, so to speak, at the FDA for patients. So we are always happy to talk to you. So that's it. Thank you.
For a sec, if you don't mind. Great, thanks so much, Susan. So I think Susan told us a lot about how we get involved with the FDA, talked a little bit about why, but I wanted to emphasize a few things that you may have heard about the why. Why are we talking about FDA and why your voice is needed in some of these interactions? So she mentioned a number of different opportunities where they're around a table having conversations about healthcare issues, different diseases or different issues that affect people across diseases. And these are opportunities to infuse the conversation with your perspectives, with COPD, to raise awareness for COPD and the issues that you face. But those opportunities go unfulfilled if there's not a COPD patient at the table or an advocate or caregiver at the table. And so these are opportunities to share your voice and to get the nation talking about COPD. It also, you may not realize it, but the FDA works closely with pharmaceutical companies as they go through their development programs. They're the ones that help make sure that the right outcomes are being measured, the right safety issues are being evaluated. And when it comes down to the time to review the treatments, that the reviewers are fully understanding of the right the risk you're willing to tolerate and for what benefit. And all of those considerations are really important to whether a treatment makes it through to the final phase. So your voice does matter here, and we will hopefully be able to talk more with you over the next year or so. And for anyone that's really interested and passionate about this topic and about getting involved, we're happy to help you navigate the system and make sure you get connected in the right places. Okay, so with that, we have a few minutes to take some questions now for our two first speakers. So we do have to use the mics, so we're gonna, Kelly, grab one in the back, and we will walk around and try to get as many in as possible here. For Susan and Tony, you have another one there to answer.
Hi, Susan. Question for you. I'm not sure you can answer this question, but I'll ask it anyway. Do you know of any submissions made by drug companies or drugs to treat COPD-related diseases?
So we would not be so we would not be allowed to share that information. It's not publicly available information yet. But if you have sort of questions about things that are already approved, I can get you to our contacts at Cedar who can talk a little bit about those. I will. And I'll give you my card as well.
Thank you very much.
Two quick questions also for Susan. First, are all of the public meetings always in Washington, or are they held throughout the country so other people can participate?
That's a great question. So mostly they are held in the Washington, D.C. area, Maryland, usually Maryland, because FDA is in Silver Spring. But because we know that it's difficult for people to travel, especially patients and caregivers who, may have mobility challenges, we always webcast those meetings, so you can participate by webcast as well. That's also another reason why we encourage people to submit comments through the Federal Register. Usually with public meetings, there's an opportunity to comment. So if there are questions that are posed within the Federal Register notice, you can actually answer some of those questions directly through the docket. And those are usually open for on average 60 days, so you can participate in that way as well. And then as far as other meetings that we do at FDA, so for example, using our listening sessions as an example, we do those sort of we've done them in person, we've done them over the phone, or we've kind of done a combination. So you can participate in that way as well.
And then my second question for you, if anyone in the room wants to become a patient advisor to the FDA, are the instructions or directions to pursue that path on the website, or should they just email Selena Miller directly, who's the manager of that area?
Yes, and thank you for mentioning Selena.
She's wonderful.
Selena is the director of the patient representative program. So if you know Selena, or I can give you her information directly, you can reach out to her directly. You can also email me if you want, and I can get you to her. But yes, so the information about the patient representative program is on our website. If you go to fda.gov/for-patients, that's the patient-specific portion of the website.
It's quite a process.
I know.
Thank you.
Thank you.
Any other questions? Okay. Well, I have one for Tony. Tony was instrumental in gathering federal agencies and stakeholders in the community for the National Action Plan for the Town Hall and getting a broad group of people together. So some agencies are harder to engage than others, some stakeholders harder to engage than others. So I would ask Tony, what can we do as a community to help push forward with the National Action Plan and help NHLBI move the needle?
Thank you. It's a loaded question, but clearly, I mean, you are the patients, and you are the caregivers of the patients. And as you know, as a federal employee, we cannot ask for money. Do we have ideas? Do we have trials lined up? Of course we do, but we do not have enough money to fund and launch all of them. And we know that they fail, right? That there is a high rate of fail. I don't know if the Losartan is going to work. We had some preliminary data that looked like it may work, but you know, that's preliminary data, right? And so you need to be your own advocate, as you have been all along, and continue to do so. Without the funding and the opportunities that you create with your voice, we can't do it on our own, because otherwise it is just up on to the investigators to come in and I had an idea, pass through the review system and hopefully get funded. And it could be funded in COPD, it could be funded in any other disease. And so if you want your disease to be taken care of or to be at least investigated, that's where you have to go and push. We have wonderful colleagues, going back to the alliances among government agencies. FDA has been at the table with us all along. We are, as I mentioned many times, we are working with HRSA. We have ideas to develop with HRSA in doing that and reach other parts of the US that we couldn't reach before. Some other parts are coming at the table at later stages because we are all different. It's like, you know, different kids in a classroom. And some others will come in at the moment that we, for example, will launch a trial, and they'll discuss with us what kind of information they need to eventually implement the results of the trials.
Okay, anyone else?
This question is for Tony. Back in 2014, when everything came about and I had the opportunity to participate at the meetings, we talked about, again, grassroots. One of the things with COPD is there's never been a standardized screening expectation. We know how to diagnose. We know what tools give us a decent diagnosis, but there's no standardization with COPD. Where are we with that process and getting that base grassroots started?
There's many ways to answer this question. One, it goes to the money. That is, as you know, reimbursement, which is something actually we're trying to tackle right now in collaboration with HRSA because of the disparity of reimbursement depending on where we are in the United States. So that's one thing. The other one is promoting research, and we have right now, Barbara actually is one of the co-investigators on that trial. We are trying to come up with new and more simple ways to engage both caregivers and patients so that we are preempting, if you want, the first phase of approach to the patient and make it patient-driven, and then the doctor will assess, depending on the results, if the patient needs further evaluation or not. So it's on both ways. On one side, reimbursement for what we have, spirometry and so on. And on the other one, find new tools that could be implemented, if you want, physically on one-on-one, and maybe eventually if they work electronically at a long distance, either on a smartphone or other electronic means.
Is there anything that we can do as a group to help facilitate that? Because as a respiratory therapist, I'm seeing disparities. It's not being done. Physicians know about it, but it waits too long. It waits way too long.
And it doesn't pay off. That's the problem for the physician. So and it's time-consuming, and reimbursement. Those are what you can do in your capacity is clearly promote awareness. This is important. We know there's another 5-6 million people probably all over the United States that have the disease, don't know they have it. We know also that the earlier we catch people, the more we can make a difference in their life. And I'm not talking just about smoking cessation, but giving them, of course, different treatments, evaluate, see what other comorbidities they have, how the comorbidities are affecting that special patient. So I think that's your role as respiratory therapists for caregivers and for patients themselves, because patients talk to each other, obviously, and share their experiences.
We will take a quick question, and then we got to move on.
Okay, I guess this is for Tony again. What can we do as a group trying to help increase the number and the time for doctors, whoever's treating us, to spend more time with the patients? Because COPD patients are often very complicated, and in a 5, 10, 15-minute appointment, you don't really get through much, and it's affecting patient care and quality of life.
Well, that's a real question and a real problem, but I do not have the answer for that. Obviously, it goes well beyond what we can do as NIH and NHLBI. It's if you want, it's more an AHRQ question. That is another agency of the government that looks at quality of care. The Q in there is for that. And are there ways that they can, because guess what? Not all diseases are the same. Not all patients are the same, and they require. I was having this conversation with Barbara this morning. Some people look at just a kidney or a heart. Some people look at the whole person, right? And usually patients are a whole person.
We hope so.
Usually.